And so moving on to our next speaker, it's my pleasure to introduce Dr. Ana Valente. She is a gynecologic oncologist with Ochsner. She actually did her residency there before going to the Stevenson Cancer Center in Oklahoma, where she mingled with one of my partners. And I've shared a number of patients with her, and I can say that all of our colleagues and patients really adore her very much. And so she is going to tell us about updates in screening and prevention of gynecologic cancers.
Good morning, everyone. Thank you, Dr. Jernigan, for having me speak today, and for all of you guys for being here. This is something that's really near and dear to my heart. We're going to talk about some updates in the ways that we can screen and prevent the cancers that we take care of every day. And when Dr. Jernigan kind of gave me the topics to talk about, I was like, oh, that's definitely what I want to talk about. And I think it's so important. Obviously, as an oncologist, I am called. My main job is to cure cancer, and that's awesome. And I tell patients all the time, there's one thing that's better than curing cancer, and that's preventing it in the first place. And so that's kind of become a big part of our practice as well as GYN oncologists, as we take care of patients that are at risk for our cancers, but haven't necessarily developed them yet. As kind of genetics is in the forefront, that has really changed the game for a lot of these patients. And so it's important, I think, not only as a provider, it doesn't matter who you are. If you're a provider taking care of patients, or if you're a brother, cousin, sister, or friend of somebody with gynecologic organs, you should be up to date on how we can prevent these cancers. So the things that we're going to kind of talk about today, we're going to cover some updates in cervical cancer screening. I think most of us are familiar with the Pap smear, but we're now using the conjunction of the HPV test, and we'll talk about the importance of that. HPV vaccination guidelines. We'll talk about endometrial cancer. Really kind of the forefront here is symptom awareness and recognizing patients that may be high risk and ways that we can help them. We'll talk about ovarian cancer and our unfortunate lack of screening, but some patients that we may be able to help from a prevention standpoint. Opportunistic self-injectomy may be something that some of you guys have heard about. It's pretty universally performed at the time of gynecologic surgeries, such as hysterectomies, where we remove the entire fallopian tube with the uterus. But it can be utilized at the time of other abdominal pelvic surgeries, and we'll cover that today. And then multi-cancer early detection tests, we'll briefly touch on that too. I don't have any financial disclosures today. So cervical cancer screening. As we know, historically, the kind of heart and soul of cervical cancer screening has been Pap smears, and women are very familiar with that. Go to the GYN, you have an exam, and we collect a cytologic sample from the cervix. But in the last decade or a little bit longer, we've been pairing that with an HPV test, which is incredibly important. Why? Because HPV is actually the driving factor behind 90% plus of cervical cancers. So the idea there is that if we detect the virus early, before it's even caused precancerous and cancerous changes in the cervix, then we're going to be able to act sooner and prevent more cancers and precancers. And so HPV testing paired with a Pap smear is called a co-test, and that was endorsed by the American College of OBGYNs as the major source of cervical cancer screening for women between ages 30 and 65 for some time now. But lately, a lot of societies such as the United States Preventative Task Force and the ASCCP have actually also endorsed solo HPV testing because it's so much more sensitive. If you look at the sensitivity comparison, you can see that HPV testing is effective in detecting, it's 90+% sensitive in detecting high-grade dysplasias. That's cervical intraepithelial neoplasia 2+. So our high-grade dysplasias are more likely to be caught if we perform a colposcopic evaluation after the patient has a positive HPV test. Cytology sensitivity is inferior to that of the HPV test. With that incredible sensitivity of the HPV test has also allowed us to space out the intervals that screening's needed. So I think a lot of patients had a lot of questions when they realized, and you may have heard family members or friends talk about this, I was previously told I needed a Pap smear every year. Now I'm being told if my test is negative, I should still see my gynecologist every year, but I may be able to go 5 years without a screen. And why is that? And it's because in the absence of HPV, the chances of developing a high-grade cervical precancer or cancer over the course of 5 years is less than 1%. And that's because the HPV test is so sensitive. So it's important for our community to be aware of that. And I think where most of us sit and most of our colleagues in general OBGYN sit is that they're performing the pap smear with the HPV test. Most people, at least here locally from what I've seen, aren't performing the HPV test alone, but that is an option. What we really want to highlight here is that our colleagues are not fine to collect the pap smear. We want to make sure we're not missing the HPV test with that pap smear. Something else that should be highlighted that's important for patients to be aware of is that we now have FDA approval for self-collection. And this is an opportunity for women who either are in low resource settings and they may not have access to a doctor. They can actually screen themselves. In 2024, we approved self-collection to be collected in an office of a physician and then given to a medical team member and sent to a lab. But now, as of 2025, we actually have at-home HPV tests that can be utilized by patients. So that's an important thing, I think, for patients in low access areas, but also we all have patients that have been victims of trauma and they may not be comfortable having a pelvic exam. You may have a friend or a family member that says, I just can't go to the gynecologist. Well, what if you could test yourself? And that's really meaningful here. Obviously, if the result's positive, then it requires action. You're going to need a pelvic exam. You're going to need an evaluation by a physician. But if it's negative, you can repeat a self-collection in 3 years, according to the FDA-approved testing. So those are kind of the real updates, are the importance of HPV testing and that we have an approved self-collection. HPV vaccination, we really want to raise community awareness and that the HPV vaccine is both incredibly efficacious and incredibly safe. So it's in our routine vaccines now for our children around ages 11 to 12. It's approved as early as age 9 and FDA approved all the way through age 45 with the opportunity to perform catch-up vaccinations in our patients who didn't have it as children. But the ideal situation is that patients, male and female patients, are vaccinated against HPV prior to sexual debut. This is a preventative vaccine. It's a virus-like particle. So there's no, it's not actual viral DNA or RNA or mRNA. This is a virus-like particle of the L1 capsid that's one of the proteins expressed by HPV. It induces the body to create neutralizing antibodies, and it's incredibly effective. So we know that in those that have not been exposed to HPV, if they're vaccinated prior, it's 95% effective in helping the patient clear HPV the minute they're exposed to it. So this is a huge deal, especially when we know that over 90% of our cancers of the cervix are caused by HPV. It's also preventative in other cancers such as vaginal cancers, vulvar cancers, and oropharyngeal cancers, which we know are on the rise with HPV as a major driving factor there. The most recent HPV vaccine, so originally came onto the market as Gardasil quadrivalent, which protected against the two most carcinogenic strains, 16 and 18, as well as 6 and 11, which are strains that can cause genital warts. But now we have 9 strains that the vaccine protects against, including many that are carcinogenic. So that's a really big deal. For our older patients that have, kind of missed the original timing of the vaccine, we can still discuss this with them, engage in shared decision making. They may harbor some benefit if they're, there's the chance that they could be exposed later in life. Also for healthcare workers, there's a chance of the healthcare exposure with us, the aerosolization of these viruses as we take care of patients with disease processes. So important for all of us to consider. And one other thing we want to highlight is the safety of this vaccine. So there's a Cochrane review that looked at 36 studies that evaluated over 90,000 patients that have received this vaccine with no increased toxicity profile compared to those treated with placebo. But like we said, 97 to 100% effective in protecting against the development of high-grade cervix dysplasia driven by HPV. In those countries that have had very high vaccination adoption rates, such as Australia, where the vaccine was originally created, we've seen a 43% reduction in cervical cancer incidence. Herd immunity effects are observed when we were able to vaccinate approximately 70% of the population. And then of importance, though, the vaccine does not replace our routine screening guidelines. So we're thankful that you're vaccinated. You should be, you have great prevention against the development of precancers and cancers of the cervix. You still need to see a gynecologist for regular screening, at least at this time. So moving on to endometrial cancer. So obviously the cervix being the bottom part of the uterus, endometrium being the lining of the uterus higher in the uterine canal. Women often develop cancers there, and this is the most common gynecologic cancer that we take care of in the United States. We don't have any routine screening. We don't have evidence to currently support that. We've looked at transvaginal ultrasounds, we've looked at serial sampling, but for a baseline population, we have not identified that screening increases or improves outcomes for women. One of the things that's really important here, though, is symptom education, and this is where I think we can all play a part. There are lots of women who don't know that bleeding, discharge, pain, symptoms from their kind of gynecologic organs after menopause are abnormal. They think, I have had patients come to me with advanced endometrial cancers that say, went through menopause 10 years ago. I started bleeding about 5 years ago off and on, and I just figured my hormones were shifting a little bit here and there. I ate something strange. My daughter had a baby, and I thought maybe I started picking up on some of her hormones and cycling again. So all sorts of different things that are true. These are things people have said to me. And so I think it's really important that in the community, women are aware that if you have bleeding after menopause, this is not normal. Please come see a gynecologist so that we can act early, because if we detect these cancers early, we're able to cure them often by surgery alone and spare a lot of downstream toxicity. So we want to make sure that we educate patients. This is really important too, because we should probably highlight, I don't think I included this on the slides, but in 2024, for the first year, we saw, that uterine cancer mortality was exceeding ovarian cancer, which obviously Dr. Riccone hit on, has traditionally been our most deadly gynecologic cancer. And so we need women to know that they can come to us with these symptoms, that's why we're here. We do have some higher risk groups for the development of endometrial cancer, such as those with Lynch syndrome. And for those patients, we can offer screening that can include endometrial sampling beginning between age 30 and 35. And the data is kind of mixed on this, but there is something to offer these patients given their 40 to 60% lifetime risk of developing endometrial cancer. We do also offer them surgical risk reduction, which is incredibly effective after the completion of childbearing, and in their 40s, we can remove the uterus and also the fallopian tubes and ovaries. A lot of the Lynch syndrome mutations also increase the risk for the development of ovarian cancer, although at varying degrees depending on which of the mutations the patient harbors. But this is something for patients to be aware of. And I think a lot of these patients are already plugged in with gynecologic oncologists because we're able to counsel them on their risk, on the options for screening or not, and on their future surgical risk reduction when the time is right for them. We also highlight for these patients the importance of genetic counseling and cascade testing. So once somebody knows they have Lynch syndrome and that they're at a higher risk of gynecologic cancers and also colorectal, of course, we want them to make sure that their family members are aware and that multiple multiple people in the patient's family are able to be tested to hopefully prevent more and more of these cancers. Other groups that can be at high risk for endometrial cancer, just for everybody to be aware of, those with Cowden syndrome have a 28% lifetime risk of developing uterine cancers. Tamoxifen users, obviously, there's probably some medical oncology colleagues in the audience that are aware of this. Tamoxifen, there's not a routine screening recommended, but patients on tamoxifen should be informed and aware of their increased risk for the development of uterine cancer so that they can be worked up expeditiously as well if they develop any sort of symptom. And then those with obesity or metabolic syndrome. I also have a lot of patients that I see come to my clinic, and I think we have undereducation on this. They're like, I don't understand how I got uterine cancer. No one in my family has uterine cancer. I didn't think I have any risk factors for uterine cancer. What are risk factors for uterine cancer? And certainly women who carry extra weight, especially central obesity, we know that excess adipose tissue is converting circulating androgens into estrogen, which acts unopposed on the lining of the uterus and can lead to the development of precancer and cancer. But patients aren't aware. They're like, oh, I knew that my weight might increase my risk of heart disease and this, but I wasn't aware that it could have implications on my gynecologic organs, and it certainly can. So we want to make sure that in those patients, we have a heightened suspicion. Maybe they're not postmenopausal, but they have a high BMI and they're having irregular bleeding. They should be sampled with a lower threshold because their risk of uterine cancer is higher. As far as ovarian cancer goes, for the average risk patient, we do not have effective screening. And unfortunately, there's no updates here. That's what I tell people. The update is there's no update. It's really unfortunate. We wish we had better screening or a way to detect this cancer earlier. But despite multiple efforts for decades, we have been unable to find a test or a combination of tests that are able to detect ovarian cancer at an early, more curable stage. The United States Preventative Task Force does not endorse screening, nor do any of our societies. The main thing we want to emphasize to patients at baseline risk is symptom awareness. So ovarian cancer can present with bloating, nausea, vomiting, pelvic pain, changes to bowel or bladder habits. The problem with this is that lots of things can present with those symptoms. And so, and women can be, we can be late to report them just because we attribute them to something else. So a persistent symptom should be worked up by a primary care physician or gynecologist. But even when that's true, we know that unfortunately we detect ovarian cancer at a late stage often. Like Dr. Riccone talked about, we haven't really moved the needle on improving mortality from this disease in over 30 years. We do have a patient population that we know we can help those significantly with risk reduction, and that's those that carry a genetic mutation that increases their risk for ovarian cancer. The top of the list being the BRCA1 mutation, and you can see the list goes on here with other mutations that increase the risk for ovarian cancer, but those with the BRCA1 mutation can have a 40 to 60% lifetime risk of developing ovarian cancer. And for those patients, we can offer risk-reducing salpingo oophorectomy, so the removal of the fallopian tubes and ovaries after childbearing is complete, and at varying age ranges depending on the mutation, and also including factors such as the patient's personal and family history into that. But in somebody, for instance, with BRCA1, the current recommendation is between 35 and 40. So the goal is that we're capturing them and removing those organs about a decade before the cancer risk really heightens. And so I think this has become a large part of our practice as gynecologic oncologists as more and more patients are having genetic testing, those with breast cancer diagnosis. I saw our breast cancer colleagues come in the back. So we share a lot of patients who found out that they have the BRCA mutation after a breast cancer diagnosis and then come to us to find out, how can I decrease my risk? I have this huge risk of ovarian cancer. You're telling me there's no screening, that the symptoms may be vague. What can I do? Please help me. And we're here to do that. The answer is surgical risk reduction, where we're able to decrease their risk of developing a fallopian tube or ovarian cancer by about 80%. An update that should be also discussed is that obviously that has implications from a menopause standpoint, but we do have an ongoing clinical trial that our colleagues at LSU have opened that the patient can have their surgery with us as well, where we're able to remove the fallopian tubes, where we think about 70% of what we've traditionally called serous ovarian cancers actually begin, and defer the oophorectomy until closer to menopause at age 50. So that's an important thing. It's called the SOROC trial for patients to be aware of, because obviously one of the major hesitations here is early menopause. And that kind of leads into this. So opportunistic salpingectomies are certainly something that we want the community to be aware of, providers to be aware of, and patients to be aware of. And this is the idea of removing the fallopian tube, taking the opportunity to remove the fallopian tube at the time of another abdominopelvic surgery. And this is pretty commonly performed with every hysterectomy and every what would have been a previous, tubes tied, tubal ligation, sterilization procedure. But we can also take advantage of other opportunities in a well-counseled patient who's completed childbearing, such as elective cholecystectomies, appendectomies, any sort of colorectal diverticulosis surgery. We have lots of opportunities that really pose the patient to minimal risk. Kind of highlight that here. Just an additional 10 to 15 minutes of surgery with a pretty astounding decrease in their risk of developing tubo-ovarian cancer. And the reason for that is, like we just discussed, that about 70% of what we've traditionally called ovarian cancers actually originate in the fallopian tubes as serous tubal intraepithelial carcinomas. And of course, the fallopian tube is a hollow organ with fimbria at the end, designed to be open so that it can take the oocyte from the egg and bring it into the uterus for conception. But because of that hollow nature, if a lesion develops on the inside lining of the fallopian tube, it can kind of exfoliate off. And then it seeds the ovary and subsequently seeds the peritoneal cavity. So the thought here being, if we can remove that fallopian tube at minimal risk to the patient, then that this is something that everybody should be offered, although obviously that takes a lot of, with a gynecologic surgery, that's easy to coordinate. With a non-gynecologic surgery, that's going to take either coordination with a gynecologist or training our colleagues in this surgery, which they're doing at other institutions or some institutions across the country. And some of the single institution studies have shown you can teach a general surgeon to remove a fallopian tube pretty quickly and easily, as you can anticipate. It's not a super complex procedure, thankfully, most of the time. The implications on ovarian function, we don't have long-term data yet because we're still in the process of collecting some of the data on these opportunistic salpingectomies. But in the short term, hormonal levels and ovarian function do not appear to be impacted by the removal of the fallopian tube. Data for greater than 10 years is not yet available, but in theory, the ovary remains with its full blood supply from both the gonadal vessels that come off the aorta and the utero-ovarian blood supply. None of that really is compromised when we take the fallopian tube. So long term, we anticipate that this would remain the same. And so the times, obviously, that this is already being offered are at hysterectomy and permanent sterilization, cesarean delivery. Again, if the patient's planning on a tubal ligation, rather, the recommendation here would be to perform a salpingectomy if feasible. And then where we can really probably start to move the needle would be in non-gynecologic cancers. There was a predictive model study that was in JAMA in 2023 that showed that if we took every opportunity for abdominal pelvic surgery to remove the fallopian tubes, that we could decrease the mortality of ovarian cancer by up to 15% in the United States. And so that's a pretty big deal when Dr. Ricconi's talking about a cancer that we really haven't been able to improve outcomes in for quite some time. So it's just something for all of us to be aware of and to consider. I can't wait to have my tubes out. That's about it. Multi-cancer early detection tests. Where are these in gynecologic cancer screening? So multi-cancer early detection tests, lots of you are probably familiar with. They're blood-based tests that analyze cell-free DNA, and they're looking at methylation patterns. So basically trying to detect all sorts of varying cancers, ideally at an early stage, targeting cancers that we don't have good screening for. So ovarian cancer, again, would be a perfect candidate for this. The data is not quite there yet. We have had some early trials that have shown that the sensitivity is variable in detecting cancers. Thankfully, it's pretty specific, so there's pretty low false positive rates, but unfortunately, there's higher sensitivity for later stage cancers. The Pathfinder 1 trial that enrolled around 6,000 patients identified 2 gynecologic cancers. One was a stage 1 uterine cancer, and the patient had symptoms shortly after, and one was a stage 3 ovarian cancer, and unfortunately, most ovarian cancers were already detecting at stage 3. So the Pathfinder 2 trial, which is going to have more prospective data on these multi-cancer early detection tests, is currently underway, enrolling 35,000 patients, and hopefully we'll have some more data. But the long long and short of it is it's really appealing. We would love to have a blood draw and an assay that detected especially ovarian cancer at an early and more curable stage. This isn't FDA approved yet. Patients may have questions about it, and we can kind of talk to them about the limitations of that. It's not improved by insurance yet. The out-of-pocket cost is around $1,000. And it's, obviously we engage in the conversations. I've had a few patients ask me about it, but not FDA approved yet. And we don't quite know what direction we're going to be going in with this. And with the key concern, of course, being false positives and invasive workups and the stress and anxiety of that. So in summary, kind of our updates from a gynecologic cancer screening and prevention. Vaccination is key when it comes to prevention, really preventing cervix cancer, vulvar cancer, vaginal cancers, any HPV-related cancer by trying to engage our community in Gardasil vaccinations. Screening changes. HPV as a primary test is now preferred for cervical cancer screening in patients aged 30 to 65. And certainly even if it's not, used as a solo test, that's fine, but we want it to be in conjunction with the cytologic test. The FDA has approved self-collection. There remains without routine screening for endometrial or ovarian cancer, but we want those patients to know, to have symptom awareness and maybe some lifestyle modification that can decrease their risk as much as we can. Opportunistic self-injectomies, something to be considered at the time of abdominal pelvic surgery in women who have completed childbearing as a modality to decrease the risk of tubo-ovarian cancer. And multi-cancer early detection tests aren't yet FDA approved. The data is still evolving here. I think that's it.